Tracy.
Good afternoon, everyone. Welcome to the call today. We appreciate you taking the time to join us, and we thank you very much for acknowledging our different starting times of about 15 minutes later than normal. This is Tracy Morton with some of the staff here at the National Rural Health Resource Center, and welcome to our first TASC 90 call of this program year. Today our call is going to focus on critical access hospital financial indicators and interventions. In June of 2012, we held a small group meeting in Minneapolis where we brought together some technical experts and financial experts, as well as some of the state flex program representatives, to talk about and really read through what financial indicators were indicative of success or failure or possible jeopardy within a critical access hospital. We had a really great discussion, and it was very interesting how easily the group came to consensus about what some of the financial indicators were and what interventions could be used to address success or failure or possible concerns as well. So that's what we're going to be focusing on today during the call. But first, we have a short update from TASC, and then Michelle Goodman is on the line from ORHP, who will be providing a brief update, as well as the critical access hospital regulatory update. And then following that, we will have a presentation by Jeff Johnson, who is a consultant and partner with Whitley, who will be providing us the content presentation. And then closing out the discussion today, Terry Hill will be talking a little bit about the financial indicator reports that are available through the Flex monitoring team.
And good afternoon, everyone. This is Terry. And kind of in that regard, we're interested in your comments on how we can make these financial indicator reports most useful. We know there's some confusion out there, and basically what we'd like to get is your feedback on how to make these reports something that you can understand, that you can use, that you can translate to your hospitals, and any other issues that you might see there as well. Just adding to Tracy's comments, you know, basically prior to this financial summit meeting we held outside of Minneapolis, there was a lot of kind of speculation as to which of the financial measures were most important. So we kind of entered that meeting with, you know, a group of financial experts, and as Tracy indicated, representatives from the State Flex program and Hospital Association, et cetera. And we asked them, what are the 10 most important indicators? The ones that, because a lot of these indicators apparently you can get different takes depending on how people interpret them. So we asked them, what are the 10 most important indicators that our Flex folks can count on to be good numbers, and secondly, give us a really good feeling for the financial condition of these hospitals. Represented, just to let you know, at this conference were folks from Stroudwater and Whitley and Bailey, and we were going to, many of you know Tommy Barnhart. He wasn't able to participate, but we tried to get those type of consulting firms, the ones that have done the most work out there, get those folks together and see if we can't agree on something so we could then give you straight information from that larger group, both as to agreements and disagreements. And as Tracy said, we got very few disagreements along the way. And we've incorporated this into a manual that we're just getting clearance on right now. That'll be accompanied by a Finance 101 kind of explanation of terms, et cetera, with a little more detail as well, which will be available to you again after that gets cleared. And Jeff Johnson, who is going to be giving our presentation today, was a participant. We wanted to make sure that that somebody from that summit meeting actually was speaking to all of you as well. So we're really appreciative that Jeff's on the phone and he's going to give this this presentation for us. And then, as I indicated afterwards, I want to go over briefly one of the reports that came out, and I want to thank Sarah Roberts in Kansas particularly because she's allowed us to have access to her report, and I want to just take a quick look at it. I want to tell you some of the ways to translate this information, and then get input and questions from you folks as well. So with that, Tracy, I'll turn it over to you for updates. Do we have many?
Yeah, I just have a couple other things I wanted to note. You will be receiving messages that will come from Kate Stenyum from our office on the activities that you selected to work on as a follow-up from the National Flex Conference this summer. So you will be, she's sending out groups and emails to those that have selected a like activity, and just to let you know that you are working on something similar. And we really encourage you to work with each other, share your kind of barriers and challenges with each other as you're going through implementing this activity along with your flex work this year. Then the TASC staff will be following up with each state in late January for just an update on progress. It's not supposed to be anything critical. We just want to see how the work is going, help you determine what those outcomes might be, look at your measurements, and just have a conversation with you about the activities that you're working on. There are, I think, 2 states that have not yet completed an activity worksheet, so if those states would please send those along to TASC as soon as possible, we can link you up with whatever states also might be doing something similar to what you've selected, and we can move forward as a complete program working on this. The other thing I wanted to make sure to mention is that the National Rural HIT Coalition will be meeting face-to-face February 6th of 2013 during the National Rural Health Association Policy Institute meeting. And that face-to-face meeting will be focusing on broadband in rural areas. If anyone is interested in more information about the National Rural HIT Coalition, you can contact anyone in the TASC staff, or Kate Stenyum is kind of the point person on the National Rural HIT Coalition. I also do know that many of the programs are waiting for the release of the State Flex Program Evaluation Toolkit, and I wanted to let you all know that we're still in the editing phase of that toolkit, but it is a work in progress. And those are all the updates I had. So I think with that, I will turn things over to Michelle Goodman, who's joining us from ORHP for an update. Thanks, Michelle. And it is *# Michelle to unmute your line.
Thanks, I just did that, thank you. I wasn't sure if Mike was also joining us. I know he was out of the office, but he said he might be able to jump on. So I just wanted to ask if he was on right now. If not, I'll go into my regulatory update.
I am on, but go ahead with your regulatory update.
Okay. All right, well, thank you all for letting me be on the call and give some information about a couple of the new regulations that have been just released. Let me see if I can advance the slide. There we go. I wanted to talk to you today about 2 new final regulations, these payment regulations that were out, and then give a brief update on the hospital outpatient supervision issues. First off, I just wanted to apologize for this one slide. It's supposed to say the final rule, not proposed rule. Again, I apologize for the incorrect slide. So on November 1st, CMS issued a final rule with comment period for Medicare's payments for physician fees for 2013. The final rule did include a statutorily required 26.5% across-the-board reduction to Medicare payment rates for physicians and non-physician practitioners under the Balanced Budget Act 1997 Sustainable Growth Rate, otherwise known as the SGR cut. This has historically been postponed by Congress each year. The rule also included a new policy to pay physicians or primary care practitioners to coordinate a patient's care in the 30 days following a hospital or skilled nursing facility stay. This is really recognizing the work of community physicians and practitioners in treating a patient following discharge from a hospital or from a nursing facility, which will ensure better continuity of care and hopefully help reduce patient readmissions. CMS has included a number of new codes, these transitional care management codes, for this coordination. The changes in the care coordination payment and other changes in this rule are expected to increase the payment to family practitioners by about 7% and other primary care practitioners by 3 to 5%. That is if Congress averts the statutorily required SGR cut. The rule also added a number of services to the list of telehealth eligible services, including certain alcohol and substance abuse assessment codes and certain preventative measures such as screening and behavioral counseling interventions to reduce alcohol misuse, sexually transmitted infections, cardiovascular disease, and obesity. The rule also expanded access to services that can be provided by non-physician practitioners. The rule allows certified registered nurse anesthetists, otherwise known as CRNAs, to be paid by Medicare for providing all of the services that they are permitted to furnish under state law. This change will allow Medicare to pay CRNAs for services to the full extent of their state scope of practice. And it also did provide an allowance now for other physicians and non-physician practitioners to order portable x-rays, which was previously only physicians could order. Moving on to the next payment system update, the outpatient prospective payment system final rule. This is, they finalized this rule also on November 1st, which updates Medicare payment policy and rates for hospital outpatient services beginning on January 1st of 2013. The rule looks to increase payment rates by about 1.8% for services provided to Medicare beneficiaries in hospital outpatient departments. Rural outpatient departments will see an increase of about 2.2%, and sole community hospitals will see an increase of about 2.4% over last year. The rule did extend through calendar year of 2013 the non-enforcement of the direct supervision requirements related to outpatient therapeutic services for critical access hospitals and for small rural hospitals of 100 beds or less, although CMS did state in the rule that this would be the last year of that non-enforcement policy. The rule did extend the 2012 Medicare EHR Incentive Program electronic reporting pilot for eligible hospitals and for critical access hospitals into 2013 without making any changes to that program.
Michelle, are you there still? I think either we lost Michelle or maybe her line got muted again. Mike, do you want to go ahead with any kind of update you might have from ORHP?
That I can do until Michelle comes back on. Hopefully everything's okay. First off, I wanted to thank everyone for their cooperation in the Flex updates. We are really using these worksheets that we sent out as a way to just see what type of barriers you're running into and what type of progress you make early on in this process. And the idea of these sheets is basically to give us a better understanding of what's actually happening out there in real-time circumstances. So your cooperation with answering the questions and working with your project officers is deeply appreciated. In addition, just to let you know that after each of those calls, we are going to have a group debrief so that we can hear what's going across the board to see if there's something that we can work on to facilitate any issues that are non-state contractual related, or if there are ways to work with different things, because we all have our internal mechanisms that slow things down a bit, and we understand that, but we also want to see if we can help with proposing any types of solutions. Yesterday, Dave Dietz did a TA call for SHIP, and that hopefully many of you participated in this, or at least had someone on there. With that call, it's a reminder that the SHIP program is changing, and the competitiveness of competitive nature of the guidance this coming year, or the funding announcement, is in such a manner that we cannot provide direct information as much as we could during like a non-competitive cycle. So we are utilizing TASC as our technical assistance arm, which they are, to provide additional information. So please do not ignore any emails related to shift that comes from TASC, because much of the information you are looking for are probably buried in those emails. So just keep in mind that because of the nature of the funding announcement this year, TASC has a great role in providing support leading up to the release and the anticipated release date of January 1st, January 15th, 2013. In addition, TASC has been working really hard on an evaluation toolkit. We've been talking about this toolkit for quite a while, and the reason why there are delays and it's coming from our review, I want to put that out there, is that we want to make sure that there are certain things captured and that we get the best possible product out there, and TASC has done a really good job of listening to our commentary and incorporating it so that when we do allow the release of this, it will be something that you can use for the Flex non-competitive. The language that's in there, the methodologies that are in there, it will create a uniformity that will be beneficial to each Flex program so that we can show an active comparison across the programs. It should not be too much longer on this. We've definitely drilled down on many things, and it's definitely coming along. I will say that with the financial toolkit, that will be out very soon. There's not much time remaining before we can release that. Our goal is for this to provide a basic understanding, and I've got to commend all the people that came to the meeting in Bloomington back in June, because this was a very fruitful discussion that's led to many insights when it comes to the finance, which is what's driven us to look at specific things within the Flex guidance. So this will be a very useful tool, and hopefully you'll be able to refer back to this webinar as a way to interpret some of the information. And just know that as we discover issues going forward, as you point out issues to us, we will try to adapt and try to help things along. With that, that's the end of my report.
Thank you, Mike. And I know Michelle was able to join us again. So Michelle, if you want to go ahead and finish up with your regulatory update, we have maybe about 5 more minutes or so we can spend on that piece before we need to move into the other presentation for today.
Yep, and I will get that done really quickly. I apologize. I actually now have 2 cell phones going, so just in case I drop one, I'll get on the other. So where was I? On the outpatient PPS, one of the things that CMS is looking into now is on hospital observation services. They did say that they will be considering future policy changes to their outpatient designation. They did not make any changes this year, but indicated that they may propose such policy changes in the future. There were no new measures that were proposed for the quality report program, but they did remove one measure to suspend data collection on one measure and then defer data collection on the 3rd measure. The last thing is that they did require, as required by law, the held harmless payments for sole community hospitals and rural hospitals with 100 or fewer beds will be expiring in on December 31st, 2012, unless Congress does extend that. They are going to, though, continue to apply the 7.1% payment increase for most rural Phil community hospital services and procedures paid under the outpatient rule. Lastly, I just wanted to give an update on the supervision issues. The CMS has released its preliminary decisions on the recommendations of the hospital outpatient payment panel on supervision levels for select outpatient services that were based on the panel's recommendations from its August meetings. CMS is proposing to reduce the supervision level for 15 outpatient services from direct to general supervision, including certain vaccine administrations, blood collection, bladder catheter insertion, and intravenous hydration services. However, did not accept 13 other services that included hospital observation, IV drug infusion, drug injection, and bladder irrigation services. These decisions are preliminary and were open to public comment through October 24th. And I do know that a number of the associations have put in public comment on this. CMS's final decision will be posted soon, and as soon as those are out, I will probably be sending a blast out to a number of folks to get that information, and also to folks here at TASC so that they can get that information to you. Those will be effective January 1st, 2013. As of this morning, those decisions had not been put in. If you have any questions whatsoever about any of the payment regulations, any regulations that you're hearing, Medicaid, Medicare, things that are going on in your state, feel free to contact any one of us on the policy team. They're all listed out here. And you can always contact me at any point, my email and phone number, with any of your questions. Thank you, and I, again, apologize for the dropped call.
Thanks, Michelle, for joining us again, and the duo cell phone backup. We appreciate it. And thanks for the update as well as great information.
No problem. Thank you.
I think what we'll do is transition then over to the presentation today by Jeff Johnson. As mentioned earlier, Jeff is going to be summarizing some of the key outcomes from the CAH Financial Leadership Summit that was held this June. We at TASC have written the summary document in the CAH Finance 101 document with folks from Stroudwater, and then asked Jeff to represent a different consultant firm, Whitley, that was present at the summit today to summarize information in the presentation today. And so I'll turn it over to you, Jeff, to go ahead with the content. Thank you so much for joining us.
Well, thank you, Tracy. Thank you, Terry and Nicole, and especially Mike as well, who was at the summit as well. I appreciate your attendance and the participation as the sponsoring organization. Everyone hear me? Tracy, I'm coming over okay?
Yep, just fine.
Okay, great. Well, I must say that as a preamble, it was a pretty cool meeting to have all the folks in the room, especially those that we're kind of competing against across the table on a day-to-day basis from Ide Bailey, BKD, and other consultants across the country and within the Midwest region and the Pacific Northwest. And as Tracy identified or Terry identified, you know, it was very cool to see us all come to agreement relatively quickly. We all worked together over the time, and all of our respective firms enjoy sharing our industry knowledge with others on this call, as well as, you know, the clients and the prospects that we work with. In terms of, you know, here's a kind of just a list of all the participants for your information. You can see it was well represented by those firms that kind of work in this space, kind of the healthcare industry, from the CPAs to the actual consultants and so forth. And then the other participants and staff, you can see were identified there. I guess, you know, as we kind of move into kind of the purpose, you know, as was articulated by Terry and Tracy, you know, what the real purpose of this was just to kind of bring together experts in the field just to identify those financial issues that critical access hospitals are having across the country. cost reimbursement isn't the end all or the fix all for hospitals. There's a lot of issues, and depending on the payer mix, which we'll talk about and so forth, cost reimbursement, the 101% of cost that they get for Medicare and some Medicaid doesn't begin to help pay for the services and the cost of delivering health care in rural areas. So as part of that, some of the challenges and provisions of the Accountable Care Act have been incorporated into some of those challenges. Our goal is to, as you can see, to identify those barriers that CAUSE are currently having, consider some definition of the financial crises and CAUSE, and you will see when the report is released and cleared, you'll see some other information in there. But my purpose today is really to just kind of go through what we agreed to as the top 10 financial indicators, if you will, of a successful critical access hospital, whether it's success being defined as just surviving or hopefully more of a thriving perspective. And then just to identify some of the strategic interventions that can and often do help critical access hospital performance. With sequestration potentially on the horizon, other cuts and changes that might be proposed. For example, the distance requirements for critical access hospitals, a lot of different things that were in the President's budget last spring that didn't come to fruition doesn't mean that those things may not pop up again. So that being said, I am going to turn our attention to some of those financial measures and just kind of walk you through those items. So it's going to be a little bit technical in nature, but I'll try to make it as non-technical as possible, not knowing how many accountants we have out there in the audience. Well, as we identified, we're going to walk through what we believed were the 10 top financial indicators for critical access hospitals. The very first one that and these aren't necessarily in any order of importance, but they do mean something different, and oftentimes the ratios are interrelated, and I'll try to describe that as we go. But one that we all agreed to that was very important was accounts receivable, days in accounts receivable, and we're going to talk about days in net accounts receivable, and we're going to also talk about days in gross accounts receivable. And as you can see here, days in net accounts receivable measures the number of days essentially that it takes an organization to collect its payments. The difference between net and gross are really how we are accounting for accounting adjustments, allowances for discounts, allowances for bad debts. I've identified in all of these ratios the actual formula in calculating the days in net accounts receivable. And every one of these slides will have a down and the last two, I didn't really make it clear in the slide, but the down and the below in the first slide, number 6, is the desired position relative to a trend or the median. The first one is the trend. So in all the slides down, for example, we would like the accounts receivable to trend downward. The lower the days, the faster organizations are collecting the cash or the bills, okay? And the median, the below, is for better performing hospitals, we would like the median, their own ratio to be below the median. So as we look at kind of what days in net accounts receivable means, high values reflect kind of a long collection period. As I indicated, we want that ratio to be low or have a downward trend or be below the median. Oftentimes, if you can improve those days cash in accounts receivable, that can mean, literally thousands of dollars into the organization's cash coffers. And now that may be a one-time event where if their accounts receivable days are at, say, 80, the median's 52, and they get down to, bring it down from 80 to 52, that's going to be a large amount of cash that's going to come in, but that's not an annual type of event. The other thing is, typically when we do see a high number of accounts receivable days, it's really could be a number of reasons. One of them, which we've identified here, is out-of-date charge masters not billing correctly. They may have a poor registration process where when a patient comes in, are they asking for the current insurance? Because the biggest problem in accounts receivable is when patients come in, they don't necessarily update their insurance may change. And in some cases, for some of the governmental payers, Medicaid can come off and on, and, depending on the situation. And when the best point in time to collect that information is right at the front end. And so if there's a lot of work that has to be done in the back end, it can take a long time to get that straightened out. It's also a good measure of how the billing process is actually working, which is somewhat obvious, but it doesn't necessarily indicate that the hospital is financially strong. You could have the best AR ratio of any hospital, but if you're not, putting money to the bottom line, or if you're not producing, or you don't have volume, you're not necessarily going to have a strong hospital. Just for matter of reference, 52 tends to be the median. The 2010 Critical Access Hospital U.S. median is 52 days. That's from the Flex Monitoring Team report that was issued in August of 2012. And then kind of the other thing that we oftentimes, or a lot of organizations will want to look at, is the gross accounts receivable. It's really the same calculation as the days net, except that you're using gross numbers versus accounting adjustments or settlements. The only reason that we typically, the goal would be that the days gross accounts receivable should be comparable to the net accounts receivable. If there's a big variance, it could be due to large settlements or big discount allowances. It may the gross and nets are close, they're close in value and highly functioning business offices. As I mentioned, there's similar characteristics. The gross accounts receivable does not include any of those accounting adjustments, and it might probably be a better measure of kind of the overall performance, because then you don't have those accounting adjustments impacting potentially what that day may look like, or those days may look like. That number isn't necessarily reflected in the Flex Monitoring report, but we typically see that number based on other reports, kind of CHIPS Almanac and some Ingenix reports from Bill Cleverly and so forth. That number is probably in that 54 to 55 range. Days cash on hand measure is a really important measure, and it's really kind of the liquidity. Again, it's another liquidity ratio. Basically, it's the amount of cash on hand that would be available if the organization, for the organization to operate if it had no additional cash being collected or received. The median is, based on the CA report from the Flex Monitoring Team, is about 68 days. Lending organizations tend to look at this ratio for financial, flexibility and so forth. It represents the amount of dollars readily available to meet those short-term obligations. When lenders look at this number for financing new projects and so forth, they typically like to see days in excess of 90 days versus the median of 68. This is kind of one of those ratios that if you have any of your hospitals in your respective states that are looking to replace or significantly renovate their hospitals, this is one ratio that will be looked upon very heavily by the lenders. Total margin is another ratio that basically measures the the control of expenses relative to the revenues. It's a profitability ratio. It's derived, as you can see, by the excess of revenues over expenses. So basically your total revenues, both patient and non-patient revenues, divided by, those total divided by your actual, more or less the net income of the organization. And so it really indicates the profits over the organization's overall profit from one year to the next. Over time, if you have a positive total margin, your net assets or the equity of the organization tends to grow. We typically look at total margin versus operating margin, which is the next slide I'll share in a second, just because the total margin includes a lot of different things, and there's different types of organizations. There's public hospitals and not-for-profit hospitals, and public hospitals or municipal hospitals typically include tax revenues and so forth, and those are not included in the operating margin, which is the next slide. So you'll see that the median for the critical access hospitals is just under 2% for the total margin, whereas the operating margin is less than 1% overall for critical access hospitals. And again, the difference between the two is one looks at the very bottom line of net income versus just income from operations, which is really just the income from operations number divided by the total revenues. And the difference between those two is just the inclusion of other non-operating revenues. And as I mentioned, municipal hospitals or public hospitals have tax revenues that may be included that help subsidize kind of the operations of the hospital. And so when we look at, as accountants and lenders, they will typically look at the total margins because there is that variance in the way that those municipal hospitals account for things versus not-for-profit hospitals. The debt service coverage ratio is a capital structure ratio and basically measures the ability to pay obligations, debt obligations related to long-term debt. And essentially it's kind of a cash flow, if you will, from the standpoint that you essentially take all your net income and you add back depreciation and interest. Depreciation is added back because it's a non-cash expenditure. It's, for depreciation, you buy an asset and you spend that cash at the time you acquire the asset, but then it's expensed or depreciated over time. And so that's a non-cash expense. And so that has to be added back. We also then add back the interest expense because we want to include that interest expense as part of the denominator when we come to the kind of operational amounts and then divide that by the principal and interest of that actual debt. As indicated here, it reflects the availability of cash flow from operations after debt obligations have been satisfied. The debt service coverage ratio represents, it's one of the key ratios in determining the ability of an organization to take on additional debt or whether, for an IT equipment or building project. The debt service coverage ratio as a capital structure ratio is highly dependent or also is very closely aligned with the days cash on hand from the standpoint of lenders reviewing these two ratios to identify the viability of any organization taking on additional debt. As you can see here, the median is about 2.58. Generally, lenders like to see the debt service coverage ratio be more than 1.5. So any facility that's 1.5 or above will generally have a favorable position in terms, and assuming they have some cash, will have a favorable position in terms of securing additional debt should they want to upgrade their facilities and so forth. Salaries to net patient revenue. This measure is really an operating revenue, and it's really intended to help review the cost of the critical access hospital in terms of its staffing efficiency. This may not be a high ratio. Doesn't necessarily mean that it's not an efficient organization, because depending on how the financials are reported, physician compensation, whether they're employed or if there's physicians that are under a contract, may or may not be included in the salary expense number. So that's one thing you kind of have to keep in mind as you look at this ratio. If you see a ratio that's north of 45%, as we've identified here as the median, you might want to ask some additional questions on, A, do you employ physicians, or B, do you have contracted physicians, because that number could skew that percentage quite a lot. The payer mix percentage is a real good indicator as in regards to the type of insurance or the type of services being provided. When you look at payer mix, generally when you see the payer mix, it'll be an overall payer mix for the entire facility. But when you really dice it down, there's really two types of payer mix because they can vary quite differently. The inpatient payer mix, which is calculated different than the outpatient payer mix, is generally much, much higher in terms of when you look at government payers, Medicare and Medicaid, especially for critical access hospitals or rural hospitals in general. I mean, generally, as you can see by the median, more than 70% of the inpatients are generally Medicare patients. That can vary depending on the size of the hospital, but for the average, critical access hospital, it's about 73%. The difference being the 20 in our example here for inpatient, the 26%, the other 27%, I should say, would be the commercial, managed care, Medicaid, whatever the case may be. If you have a high Medicaid population in the county or the community that the hospital is in, you could very well be up to 80% of your payer mix being governmental payers, Medicare and Medicaid. The outpatient and the inpatient is calculated based on days versus charges, because there's a lot of different things that go in the charges and capturing that amount of resources used for inpatient beneficiaries of inpatient stays. Outpatient, on the other hand, is calculated based on charges. Only because, with inpatient, there's a patient, in the bed, and it's easy to count the days. Whereas outpatient charges are used versus number of procedures, because if you look at a surgical procedure, you may do, a facility may only do 200 or 300 of those throughout the entire year, but then for labs, they may be, reporting 50,000 lab procedures. So it's not a good measure by using procedures. So generally, charges are the mechanism for measuring outpatient payer mix. And as you can see by the median, inpatient is very highly Medicare utilized, whereas outpatient is not as utilized because you just have a more broader population of patients that are using the outpatient facilities versus using the inpatient component of the facilities. The other thing I might add is that under the, which isn't in your slide, but under the EHR incentive payment for critical access hospitals, they use the inpatient, for acute beds, inpatient statistics as part of that calculation to determine how much of the cost will be reimbursed on the EHR that they place in service. And as you can see, for those of you that are familiar with that process, if the average critical access hospital, and this is in general, but if the average critical access hospital for inpatient is 73%, or the median is 73%, when you add the 20% add-on as part of the EHR incentive payment, you're up to basically 93% of the cost of that EHR that a critical access hospital installs or implements will be reimbursed by Medicare. And in some cases, it's up to 100%. You can't go over 100%, but in some cases, it's 100% of that cost is paid for under the Medicare program. Another value that is that we felt as a group that is a ratio that is important to look at is the average age of plant, and this measures how old the plant, how old the buildings and the equipment of the organization are. Again, it's considered an operations ratio, but it's basically determined by taking your accumulated depreciation, which is the depreciation expense on all the equipment that's accumulated over time since the beginning of the time that asset was put in service, divided by the current year's depreciation expense. And when you look at that, when the value is low, as you can see, the median is 9.9, but when the value is a low number, that means that that it's a newer facility, or the excess cash or cash from operations that the facility may generate, they invest a lot into their building and equipment over time. The status of newer facilities has, by doing that, and that can be a double-edged sword by investing that cash, because if you continue to invest cash into the bricks and mortar, you don't have, your days cash on hand tend to suffer and becomes a lower number, or oftentimes is below the median of 68, as we identified in the second or third slide of the ratios. However, the status of newer facilities has been shown to have a very positive effect on recruitment and retention of physician and staff. So clearly, you as a user of the healthcare system, you feel better about going into a newer contemporary hospital, one that's been updated, versus kind of the old Hill-Burton, which I know a lot of your constituents have a lot of older hospitals and oftentimes struggle to meet the bottom, or to have a bottom line. But it's kind of difficult if you don't have access to that capital or the cash to upgrade those facilities. But if you have a newer facility, they can also recruit and retain much better, potentially offer additional surgical services and different things like that. Long-term debt to capitalization is another capital structure ratio that kind of ties into the average age of plant, ties into the days cash on hand, debt service coverage ratio. They all kind of tie together. Really measures the percentage of the net assets, or as I referred to earlier, the equity that, the percentage of net assets or equity that is debt related. So in other words, a high value is typically not a good value to have, because you want to have a low value from the standpoint that you're using your investments or your operations over time to help fund those capital projects. But we all know that it's we do have to go out to the market to borrow money to make investments. We typically see this ratio, again, measure the amount of capital that's financed with debt. Again, this is important to lenders. If you have a high value, in other words, you're very highly leveraged, then the hospital is going to have a hard time securing additional debt to make improvements. As you can see here, high values signify a risky situation and may have a hard time sustaining debt payments in the future if things go bad. If you have a downturn in the economy like we have in the last couple of years, you're seeing a lot of hospitals start to, you have been seeing hospitals margins kind of deteriorate and having a hard time in terms of operating, which is the point of this summit. We do expect this ratio to increase over the next couple years. We are seeing that, through USDA and HUD and others, that there are some funds available via direct or guaranteed loans from the federal government, and that money is cheap for these hospitals to access. If they're relatively in good shape from a financial reporting standpoint, you can get some significant amounts to upgrade facilities at a very low interest rate. And so we expect that because they're going to take on this additional debt, that we expect this ratio to increase a little bit more as hospitals try to upgrade the facilities over time. Any questions on those ratios? I don't know. Tracy, do we want to just take a second to ask any additional or questions on these, or do we want to just kind of go through the next part and then kind of have the questions at the end?
So if anybody has any immediate questions, Jeff, we can take them now.
Okay.
Anybody in particular? The other thing you can do, can you email?
Yes, they can email.
You can email us questions as well, or you can just ask them as well. Part of what my thought would be, this would be extremely useful information for hospital boards, that it would provide 10 measures that they could count on, that they could maybe get their hands around, et cetera. So besides the state flex programs, we thought this information would be useful for the hospitals and the hospital boards themselves.
I agree, Terry, wholeheartedly. In fact, as we kind of look at the kind of interventions, financial interventions, we can kind of boil it down into, three kind of categories in my opinion, as kind of described in the document that will be released in the near future, is kind of looking at review and assessments of the operations, education, and then collaboration. And under the education bullet is where we typically, all of us consultants and CPAs out there, when we're providing, the end of the year audit results and different things like that, there's often times where we're asked to come in, maybe a couple of hours beforehand, just to kind of give them an update or kind of give them some board training on how to read financial information. And in fact, many of the state hospital associations have governance type training for board members of critical access, board members of any hospital. But we find typically that the critical access hospitals generally need the most training and often are the most attended in these sessions, because the board members are farmers. They're the local businessmen that maybe don't have a lot of healthcare knowledge, and it is a different animal, as you all know. And so we often do these types of presentations for these state hospital associations. And in fact, there have been instances where we've worked with some state offices of rural health or health, cooperatives, if you will, that have received flex funds, and we'll go in and do some education on various financial kind of 101, critical access hospital 101 financing type things like that. So I agree, Terry. This would be a good baseline to kind of kick that off. So with that, if anyone has any questions, again, email me or speak up, but I'll just kind of continue on. In terms of, as I mentioned, when you look at the different CAW interventions to help hopefully improve the ratios that we just described, there's kind of three areas that I've identified, and one of those is reviews and assessments. And what I mean by that is actually, okay, the cost report is a very important tool, or a very important reporting mechanism for critical access hospitals. This is how they get paid. It drives the Medicare payment, and in many cases, in many states, it drives the Medicaid payment as well. And so errors on these cost reports can really affect the hospital's bottom line. And it may be errors may include incorrect allocations, the way the cost report works, or inaccurate statistics that are outdated, that have not been refreshed. Most of these cost reports are outsourced to accounting firms, but not necessarily all accounting firms understand or are real adept at understanding critical access hospitals and the way they work. There's a lot of different things you can do with the cost report. For instance, a hospital may own and operate, or maybe just recently acquired a physician practice. And so how do we treat that physician practice? Do we have them as a provider-based clinic, or do we have them as a provider-based rural health clinic? Or do we treat them, or should they be treated as a freestanding clinic, or whatever the case may be, or not even part of the organization? Another item is many critical access hospitals have attached skilled nursing facilities, nursing homes. And we have seen, and in many cases, it makes sense to kind of spin off that nursing home from the critical access hospital. And the reason for that is because in some states, the nursing home may be reimbursed based on some cost up to a limit, but it's hurting the critical access hospital because of the cost allocation methodologies as a result of the cost reporting process. So there's a lot of complexities, if you will, in terms of the different types of services that are being offered in a critical access hospital that may make some sense to restructure them in one way or another. Another kind of assessment or review is kind of looking at strategic or financial and operational assessments. They help identify specific opportunities for the critical access hospital. Again, matching services to community needs. And in this case, as the not-for-profit hospitals, the 501c3s, excluding the public hospitals, are going to be required to report kind of a community health needs assessment, which is required by the IRS. And as part of that process, you can use that process as part of the strategic planning initiatives of the hospital, because there's a lot of similar data collection and market analysis that is being conducted at the that basically can cascade down into the strategic planning initiatives and help identify those tactics in addressing the services that are needed in a community. Staffing benchmarking is another area that is often, how many business office folks do we need for the size of our hospital? Do we have enough? Do we have, too many or not enough? The clinic management, how do we operate the clinics? And again, do we operate as a rural health clinic? Do we operate as a provider-based clinic? There might be a reason why it shouldn't be a rural health clinic anymore, for one reason or another. And as a rural health clinic, you have to have mid-level, non-physician practitioners as part of the provider staff. And if you're having a hard time recruiting those you have a hard enough time recruiting physicians, and sometimes it's even more challenging to recruit non-physician practitioners. Medical staff planning, again, we find in a lot of communities we have physicians that are 60, 70 years old. They're still practicing. They're the old Marcus Welby, MD type physicians. They do everything. But the newer physicians today don't necessarily want to do all the types of things that the older physicians are doing. And my point in medical staff planning is at some point they're going to retire. And so you have to have a plan, these hospitals have to have a plan in place to make sure that they're recruiting and identifying those physicians so that they can always have a pipeline of physicians coming into the community. And you need to right-size that, know what the staffing levels and what those staffing levels need to be. Do you need 2 or 3? Do you need 2 family practice physicians, or do you need 3, or do you need 2 nurse practitioners and 1 MD or DO? And so those are the types of things that we're talking about when we're looking at these types of analysis. And as you all know, the lifeline for a hospital is the physician staffing. Now I know there's some of the older CEOs that typically that may think that the hospital drives the revenue source, but really the physicians are the lifeline to a hospital. The best, if you have a hospital that has, and the CEO and the physicians have a really good relationship, you're going to be able to find if that's the case, then that hospital is thriving, not just surviving. Revenue cycle management, another key aspect to critical access hospitals. I mean, they get paid based on what they do. These activities should result in, when going through this process, there's several organizations that can help do charge master reviews and revenue cycle reviews, looking at the business office, the front-end collection, the front and back-end billing component of those hospitals, making sure they have the right staffing, looking at pricing, are your services priced appropriately, making sure that you're in compliance with the Medicare program. We're seeing that the CMS has, the RACs and so forth, have pretty much left the rural health clinics and critical access hospitals alone in terms of in terms of compliance reviews and medical necessity and things like that. But I don't see that continuing. I see that as an area that they may start to focus. Even though critical access hospitals are a small percentage of the overall Medicare budget, it's just Congress and the Hill is looking for a lot of cuts, and these are areas that are, could be, some low-hanging fruit for CMS. So just making sure that those things are the revenue cycle is being reviewed, not just from that standpoint, but we find oftentimes that charge masters are not being completed at least annually, and they should be, because as I believe it was, as Michelle indicated, the CPT codes and the changes in the types of services being, included or excluded from Medicare on an annual basis are often a lot of different types of services, and so those need to be reviewed to make sure that you're not outdated and also billing for services that you can be billing for that maybe weren't available services in the prior year. So the charge capture process is important. Physician practice management assessments, again, another important area. We're seeing, like no other, at record speed, we're seeing a lot of physician practices, independent practices being acquired or merged into hospitals in rural areas, not only in rural areas, and we're also seeing critical access hospitals being acquired by larger health systems. But in order to kind of, position themselves for ACOs and the Accountable Care Organization tidal wave, these physician practices are being acquired. It's, operating a physician practice is very different than operating a critical access hospital. So they need to make sure that, when these practices are operated under the hospital, that they understand what services are being offered, and that they are, generating money and not losing money. A practice management assessment includes looking at physician and non-physician productivity, provider productivity, kind of relating that to compensation. For not-for-profit hospitals, you know, you have to pay physicians at fair market value, and the IRS defines or gives a guidelines of what that means. So if a physician is being overpaid for the production that he's providing, there could be some annulment issues or Stark violations, things like that. Scheduling practices, revenue cycle similar to hospitals, the fee schedule reviews, billing and collection practices, looking at overhead and support staffing, even looking at the physical layout and the patient throughput. When we go in to do rural health clinic or medical practice assessments, oftentimes efficiencies can be gained by just rearranging the throughput of the patients. And then, as I mentioned already, the clinic structure as it relates to the hospital, provider-based clinics, rural health clinics, and so forth. All of these assessments that are generally conducted by a third party should have, specific recommendations and action plans on how to, to develop and generate additional revenue. Just finally, to kind of, in terms of education, some of these things you can read here, but lean process improvement training is an area that is really taking on has a lot of momentum. I know that the Terry Hill and Tracy and their staff provide some of this service or provide this service as well, training and so forth. We're seeing a lot of this. It is a good tool or a good process. Lean can be kind of intimidating, but the process itself is not as intimidating as it sounds. And I think you're going to see a lot more of this happening, especially as you see hospitals kind of work together. Financial education for the department managers, we talked about that. Generally speaking, I think this is a good discipline for hospitals to make sure that their department managers understand the ramifications of what critical access hospital means. Charge masters, the importance of the charge masters, and attending workshops. Make that investment to attend those workshops that you guys put on, and oftentimes fund. But there's other opportunities through various state associations as well. And then, as we already talked about and Terry alluded to, financial education for critical access hospital boards provides, a good fundamental grounding on cost-based reimbursement and just financial management of the hospital itself. It's a very complex, critical access hospitals are complex organizations. I know I've done some presentations to even some of you where I put up a grid up there that shows all the different service lines and all the different payment methods that a critical access hospital may have to manage. Collaboration, again, developing CFO networks, see a lot of that happening either through some state cooperatives or even some of the flex coordinators or the flex offices coordinating some of that. Pooling some of the dollars to provide, more means of financial and lean education, getting that economies of scale to work together. That can be sometimes difficult when, in some states you have hospitals that are 10 or 15 miles apart from each other, or maybe 20 miles apart from each other, so there's a sense of competition there. But maybe it's looking at, what are we good at and what is the other hospital good at, and maybe focusing in on those service lines that they really excel at so that they can work more collaboratively together. Benchmarking, financial indicators is another way or means of measuring performance, comparing results. Of course, the flex coordinators have, the flex monitoring team provides a very, very useful benchmark report that I believe Terry's going to speak on in just a few seconds. And I guess that's the end of my discussion. So if there's any questions, I think I ended pretty much on time. Maybe I'm a little over.
actually, I think you started 5 minutes late, so you did perfectly. Thank you so much. Jeff, we have a question about where's a good source of staffing benchmarks? You mentioned, looking at the staffing benchmarks. Where would be a good source of getting that information?
Well, that is a good question, and Greg, thanks for bringing that up. There are some sources. And we get this question all the time. There really aren't very good sources to look at staffing from business office and so forth. One thing that we, I don't want to, I guess I'm not, there are benchmark reports out there if you want to contact me that I can provide you that include grabbing information from your own internal records, and we have developed a critical access hospital benchmark report that basically takes information and includes currently about 100 critical access hospitals in the survey, and it actually looks at various departmental type of benchmarks, ER, business office, as it relates to the size of the organization of the size of the hospital. And Terry, I can provide you a copy of that report if you want to share it with the group.
Terrific. I appreciate that. We've got some other questions coming in here. Let me just say, as they're coming up on our screen here, the complexities, and I quote this quote from Peter Drucker, who's one of the ultimate management gurus, and that is, hospitals are the most complex organizations in the history of mankind. It is not an easy job, and it's getting tougher all the time. I mean, there's 6,000 different medications, and there are thousands and thousands of medical procedures, et cetera. To think that one small group of folks in a rural hospital could do it all is so difficult, and it just generally doesn't happen. So one of the things that we really recommend is, first of all, find good consultants or help refer them. One of the real good things about having everybody together is because we've heard, well, people like Jeff and Whipley and Stroudrun and whatever, they have a vested interest in saying these things. And now I think one of the real steps forward here is that we're all talking pretty much the same language. We've included, a variety of different types of folks as well. Greg Rosenthal, for example, is a former CEO. He's our flex coordinator in Utah. Those are the kind of folks who are at that meeting. So we feel that these hospitals are going to need good consultants, but find the right ones. And again, TASC can help you with that, give you some options, etc. A second, and this we've learned in the Mississippi Delta Project, and I want to commend Bethany Adams now, who's part of our staff with this, is if we do a good job on the front end of clear expectations and being real intentional in terms of what we're intending to accomplish with these consultations, we get way better outcomes on the back end. So that whole consultation process is one that I think through the Rural Hospital Performance Improvement Program, we've gotten pretty good at that and more than willing to share those processes as well. The consultants tend to appreciate it because it's clear what they're looking for, and the hospitals very often aren't very explicit in terms of what they're hoping to accomplish as well. So use that process, or use a good process going in, and that way you're keeping the accountants or you're keeping the consultants accountable, and in essence you're maximizing the use of scarce dollars, etc. Let's see, we've got Anthony Jones ask, he's got some questions about are there guides to best practice templates for developing any of these slides?
Are there guides? Let's see, I'm just reading. Are there guides?
Best practice templates.
Yeah. Yeah, I mean, there's kind of a related question I think someone else posted regarding what's the typical shelf life of a financial operational assessment? And it's, I guess the question would be whenever an operational or financial assessment is done of a hospital, they generally develop kind of a baseline. Here's where you are at now, kind of the current state. And then based on looking at your own internal ratios and comparing them to the benchmark reports, whether it's the Flex monitoring team or the Ingenix CHIPS Almanac, which is another resource that's put out by Bill Cleverly, or other internal, we ourselves, because we work with more than 300 critical access hospitals across the country, we have quite a few of our own benchmarks. And so we kind of look at that, and then we said, okay, here are the targets, and then if your days cash on hand are at 10 or 15, and you desire to have a building project in the next 3 years, and you need to be at 60, what are the action items you're going to do to get there? And whether it's in terms of the shelf life, my opinion is that these financial assessments that are done can kind of tie into your strategic financial plan, which if you have a strategic, most of the facilities that I see out there, critical access hospitals or hospitals in general, they will have a strategic plan for their organization. I see one of two things. Number one, they take that strategic plan, they go through the process, they include the community, they include the board, and then they put it on the shelf and they look at it maybe once a year, if that. The best way, the better performing organizations, that strategic plan becomes their data, as their Bible. It becomes the resource on their desk that they refer to almost on a daily basis. As part of that strategic plan, they should have a strategic financial plan, which basically the first year is the operating budget. The second year is kind of your projection of where you want to be. And in my example of you have days cash on hand at 15, and you want to make a significant renovation or build or replace some hospital, and you need to get to 90. Well, how are you going to get there? And those are the so that if you're looking at that assessment that you already had completed 3 years ago, and if you look at the financial ratios compared to the baseline or the benchmarks that you established at the beginning of the process, if you've improved, then you need to just, hopefully you've improved, and if you haven't, you need to go back to see what those recommendations were to get you to that point.
Thanks, Jeff. And in essence, the shelf life itself, the recommendations that come out of a really good consultation basically generally need to be implemented over a course of a few years. So in essence, they may still be very relevant, and what would probably be in order would be some sort of a follow-up to see, instead of doing an entirely new assessment, follow-up to see how the hospital might have followed through on that assessment that was done 2 or 3 years ago along the way. There's another question about the availability of education for critical access hospital department managers. And we have access to a number of different pieces of curriculum. But I want to mention again a source that I think is vastly underutilized, and that is we've done a tremendous amount of education in the Rural Hospital Performance Improvement Program. As you recall, we've been doing that for the last dozen years. And this past year, we had, about 22 different sessions, including a 4-part series by Eric Schell, directed specifically to critical access hospital managers. Those are all have been stored, have been done within the past year, and all are accessible to you. So we really, we're going to give you guys much better access to all those tools and resources that have been a part of the RHPI program. We've been given authority by the Office of Rural Health Policy to share it with everybody. And before you go out and create a 4-part series on critical access hospital department manager financial training, please look at these because not only are they available, but they are absolutely excellent. And we can show you the evaluations on them, et cetera. So again, I think we've mentioned this before, but gee, there's so much information out there. Again, just want to refer to this really good work that is going on there. And we can send the link into all of those materials. That includes ICD-10, lots of stuff on financial improvement, quality improvement, et cetera.
Yeah, and I might add that, you know, what I've seen, as I mentioned at the onset, there's been many times where we've been asked to come in and do some, you know, kind of finance 101 or department type education on various aspects of kind of the hospital operations, whether it's financial in nature or more operational in nature. And generally, you know, the fee for a consultant like myself or any of my colleagues on the participant panel is not, it's pretty nominal. So, I mean, we look at it as an opportunity to give back to the industry as well.
Yeah, thanks. That's a really good point, Jeff. And again, if you can get a group of hospitals together, what I've found is that folks like Jeff and Ralph Llewellyn from Whipley or Eric Schell, et cetera, are generally willing to you know, do some sort of an educational session. And with folks of that caliber, you really can't go wrong. We also have a question from Anthony Jones here about the CFO networks, how to develop one. And I guess what I tell you is let us know. We can put you in touch with some folks. Michigan has a terrific CFO network that meets periodically, but I think there's 11 others out there as well, Anthony. So we'd be happy to tell you how to do that, and then maybe give you, you know, reference to somebody, a bunch of folks that could tell you how they did it and kind of how to set the agenda, et cetera, et cetera. We'd be happy to help with that. I think with that, because we are going to run out of time here, I'm going to thank Jeff very much for that. If you have follow-up questions, please don't hesitate to either contact us, and we will pass them on to Jeff. Here also is his contact information. We've used Jeff in the past in our Flex workshops, and kind of again, just want to say thank you very much, Jeff. I thought you did a really good job of that. And as I watch you kind of go through the presentation, I thought, you know, that group really did excellent work, and I think this is going to be very useful for our Flex program people and hopefully the critical access hospitals as well.
Thank you. Appreciate the opportunity.
Okay, thanks. Okay, we're going to move to the last portion. Remember, if you've got questions about any of this, do contact us, and we will follow up with Jeff or you know, our other consultants. Generally, we have a whole crew of folks that we rely on to get our financial questions as well. I wanted to just take, you know, what time is left here to take a look at one of those financial reports that you're getting from North Carolina. And again, Sarah Roberts was very gracious in letting us use her report here. You guys have got these. By the way, the Medicare cost reports are public information, and I have sources, for example, of getting those reports on individual hospitals, et cetera. So there are sources if you're looking for for example, the 2010 cost reports for your state. Do let me know. We don't have them here located at TASC, but we've got pretty good sources out there. I was out in Kansas a couple of weeks ago, and Sarah and I sat down and really went through this cost report. And I want to just show you a few things here about her cost report and how maybe to interpret a little bit as well. And then we're trying to give input to the University of North Carolina to make these as useful as possible. But what you can see here is on this first part that the Kansas hospitals have really struggled financially. There's a variety of circumstances to that. One of the things I will tell you, and particularly if you talk to them, is their Blue Cross Blue Shield payments have generally been lower than a lot of other states. For example, significantly lower than Nebraska, which is right next door to them. And if you look at the Nebraska numbers, which I'm not going to put up there, you can see that Nebraska financially has been doing a lot better than Kansas has been doing. But basically what we're seeing here and what Sarah's facing is that all of the numbers that like margin and cash flow margin, return on equity, operating margin, etc., are lower than the median across the country. Her equity, the debt service coverage, the long-term debt, where she's going higher has to do with Medicare inpatient payer mix and Medicare outpatient payer mix, and I'm going to talk a little bit more about that on the back side of this particular report. Remember, it's a 2-page report here. You can see her salaries to net patient revenue is higher, which is not good. Her average age of plant is higher, which is not good as well. And so those are indicators that are telling her that for a variety of different reasons, the Kansas hospitals are struggling. Let's see, are we, okay, can you go down a little bit further on the page? And here we're seeing benchmarks, which we're understanding are not the median, but the benchmark that North Carolina is proposing here. And again, you can see her hospitals are basically 32. They're at 32%, which you want to be higher on the average age of plants, or interpreted, you want to have a newer facility. She's at about only 25% of her hospitals are benchmarked. So that basically is indicating again that the numbers under 50% here are indicating that there's some real problems in this particular case. So keep going. Go to the next page. Now here I want to talk about this just a little bit. Basically what it's showing is the box is the 25 percentile. So the left-hand box is the 25 percentile, and the right-hand box is the 75 percentile, and then the line in the middle indicates the median for her hospitals here. What you can see is that a total margin is sitting at about, about 25% or something of that nature, meaning that her hospitals are struggling here. I want to point out just one quick thing as an interpretation. So you can get all this information and then you can say, well, so what? That means we have problems here. But I want to point out a couple of things on this. Look at our Medicare inpatient payer mix and the Medicare outpatient payer mix. Those hospitals are up at somewhere around 82 percentile. So that means that on average, only about 18% of the hospitals are any higher in the country on this. And what we know in Kansas, for example, is that they have a number of hospitals there that have been trying to make money or with a success factor of trying to maximize the Medicare costs. And I just want to point out that generally leads to some of the numbers we're seeing here. In other words, the formula for success for critical access hospitals is not maximizing your Medicare costs or even your Medicare patients. It's having a good payer mix and having volume. So the bottom line here is volume is the golden formula for critical access hospital success. That means you've got to keep the patients in the community. You have to keep people locally. And that really speaks to the crossover now of why we are working on our community assessments or the work that we're doing in the communities. We know, and there's been a recent study in Tennessee, we know that over 50% of the rural hospital service area folks that are using hospital services are leaving that local hospital district. And we know anecdotally this is a huge problem. So I just want to point that out, that in essence, we've got to keep people locally, and the community work that is being done will directly impact that financial performance. The other thing I want to point out is salaries to net patient revenue, which is showing up there, looks like fifth from the bottom. And that basically is also high around 80%. And what that basically means is either they have too many salaries, too many folks on staff, or not enough revenue. So I wanted to point that number out as well. And I think if you combine that, basically what that diagram shows me is the Kansas hospitals basically don't have enough volume, and particularly non-Medicare volume, and that one of the things that they can be doing is to try to keep more folks locally, which would mean develop services, go out to the community themselves, find out why they're leaving, and see if you can convince them to stay locally. So that's just one of the ways to look at this. Again, we would like feedback from you. We don't have time to do it today because we're right at the end of our time, but we really would like to make this report coming out of North Carolina, and I know I speak on behalf of George Pink and Mark Holmes and those folks as well, as useful as possible. So it's one of the ways I've tried to explain a little bit of why Kansas is struggling. It's got problems with its Blue Cross Blue Shield, but believe me, that is not the only issue they're facing. A lot of it has to do with the volume, and you can see that from the numbers reflected here as well. So with that, again, we don't have any additional time. We're going to end on time. Tracy, anything else that you have to say? I think we're really excited about the documents that we're sending out, as Tracy indicated before. You should be receiving them shortly. That was good news from Mike today. And do call us or email us if you have any additional questions here. And with that, I'm going to say goodbye to everybody.
Thank you, Terry.
Yeah, bye.
The meeting is now over. All the participants have been disconnected.